for
All right, just for the sake of time, I only have an hour. I might start now. I know you guys might be trickling in, but that's okay. Just a short introduction. My name is Ellie. I'm the lead TA for Cardio Pulm. I know I'm not one of the head TAs. It's a bit of a shocker, but if you guys have any questions, unfortunately, when I put up my notes, I can't see the chat box, so you might have to turn on your mic. Sorry about that. Or you can just email me after. But I did send in the chat the notes that I have. I did not know you guys usually use slides for these, but it's going to be the same thing as usual. I'll just go through the objectives. I'll find any information that I think you guys should probably at least know decently well for the exam. Um, and if you guys have any questions, please reach out. But starting off, I know everyone hates embryo, but I was thinking it might be a good idea to start with embryo just to, it seems to be a little bit trickier for people. So that's where I'm going to start with those objectives. Let me know if you guys have any questions. Okay. All right. You will notice I deleted the first objective. That's solely because that one I put into another objective. So we're starting off with fistulas. So we're talking about atresia and fistulas. What we're essentially talking about is how when the GI system develops, it's supposed to split. It's supposed to split into your trachea and you're supposed to split into your esophagus. Unfortunately, sometimes that fails. For fistula, this is unfortunately due to the failure of partitioning from when you have primordial pharynx and the larynx, and that's what is caused by the tracheoesophageal septum not really developing properly. Of course, I'm sorry, these are a lot of big words, but I have a time crunch. All right, but starting with an atresia, this is when the upper esophagus just ends blindly. Like it's not going into anything else, it just stops. In this case, it can cause a lot of vomiting, just a lot of GI problems. And for this, you're not going to see a lot of the lung-related issues like spit up or coughing. For a tracheoesophageal fistula, this is an abnormal connection between the trachea and the esophagus. So especially with that one, you're going to see either the food's going to go when you swallow it right into the lungs. You might get some cough up, and that's another big problem. So for these guys, I have a very nice little picture. For the exam, if I remember correctly, you're probably going to get a picture like this, and they'll give you like a clinical vignette, which will be something along the lines of a child presents, they're having projectile vomiting, their lung sounds fine. So I'm just reading off the first one, but they'll give you some type of vignette, and then they could be nice and give you the name of what it is, and then ask you, which one of these pictures represents that. Or you might need to just know what the symptoms are and then pick which one it is. Yeah, thankfully, like the names kind of give it away. So, if you see a fistula, that means it's a connection. If you see just atresia, that means it's not connecting between the trachea and esophagus. It just means it's just stopping. So, yeah, that's just a good way to remember those two. It's just to know what they mean. And again, if you have any questions, please, you gotta turn off the mic. All right, so going into lung maturation, this is a bit long, so bear with me. So lung development starts with the endoderm. It's going to develop into pulmonary epithelium, the glands of the larynx, trachea, and the bronchi. Then you have the foregut splanchnic mesoderm. That's becoming the CT, the cartilage, and the smooth muscle. I don't remember if you guys remember a lot of the stuff that you covered from the last couple of mods about embryo, but remember you have the endoderm, you have the mesoderm, and you have the ectoderm on top. Ectoderm is going to go off and become a lot of the skin and stuff, so it's not really that deep for this stuff, but anyways, so going into the first sign of respiratory development, they really harp on this in the slide because it is important. It might be an exam question. The first sign is always the laryngeotracheal diverticulum forming. This is usually around the fourth week. Essentially, it's like the endodermal lining of the foregut is going to vaginate downward and it's going to form it. So it's really at the bottom of those pharyngeal arches. So the laryngeotracheal diverticulum is going to form the laryngeotracheal groove, and that's going to form the laryngeal inlet right in the center. And that's that guy right here. You're also going to have your pharyngeal arches, which are going to be right above it. 4 through 6 is going to become the muscle and the cartilage of the larynx, and that's what the vagus nerve innervates. Then going down, these pictures are pretty helpful if you guys can look through them on the slides. Again, I know me talking about it might sound a little bit confusing, but even if you can just write it through, like go through each one of these part by part, it makes it a lot easier. It's how I learned embryo. But yeah, just draw it out. So yes, you have pretty much all of this development here. You see the diverticulum forming. Then you're gonna start to see respiratory bud, and then the respiratory bud is gonna pretty much break off into the primary bronchial buds. I'm gonna talk about that in a second. And then you also have the tracheoesophageal fold. Then you're gonna see your primordial laryngeal tracheal tube. Your group's gonna form pretty much all the stuff I just talked about. But yeah, so then you have your esophagus and your trachea. That is this the point where you start to see the fistulas and the atresia is this part right here. That's the clinical correlate for it. So they probably won't ask too much about these couple of pictures here, just because that would be the correlate. That wouldn't be a separate question, but anywho, all right, so week 5, your bronchial buds develop, as I said. Then you're gonna start to see branching. There's 3 main bronchi on the right, remember that, and 2 on the left. Lung maturation. This is really important. So going to it, there are the 4 phases. So you have pseudoglandular phases first. That's 6 to 16 weeks. This is just the beginning part. You're going to start seeing your endodermal tubes. You're going to see the simple columnar epithelium, a little bit of capillaries. You have no alveoli left, and you have no respiration. You're still reliant on no respiration yet. And canicular phase is 16 to 26 weeks. This is the part where people get a little bit confused, is the fact that it says at before 20 weeks they can't survive, but canalicular phase is 20 or 16 to 26 weeks. So there's like 6 weeks that aren't accounted for. That's because we can produce surfactant, like we can give them an artificial exogenous surfactant that'll keep the baby alive if it's born a little bit premature, before the terminal sac stage. That's that 26-week mark. That's when you start producing surfactant. Surfactant is produced by type 2 pneumocytes. There's pretty much this type of simple cuboidal epithelium. There's going to be type 1 and type 2. Type 1 is more for the blood-air barrier with the capillaries. It's for gas exchange. But yeah, I know I went through that a little bit fast. But yeah, the big takeaway from lung development is knowing the weeks, knowing that if the child's born before 20 weeks, they're going to go into respiratory distress, and we can't help them survive. Of course, there are like exceptions to the rule, and miracles happen, but yeah, before 20 weeks, it's unlikely. But after 20 weeks, we can try and give them artificial surfactant. And then at 26 weeks, then they can start producing their own and they have a better chance. Then last, you have alveolar stage, which is 32 weeks to 8 years. This is pretty much when your lungs are just developing a bit more. You're increasing alveoli, and you're pretty much making the transition from being dependent on the placenta to be able to do your own gas exchange. Yeah, it goes all the way to 8 years too, which is kind of cool. And then lastly, for the last objective is the diaphragm. For this, I mean, it's just point blank memorization. Maybe the most important one I would tag would be septum transversum. That guy just becomes the central tendon, which we'll talk about in a second. Yeah, central tendon is just the very important middle center for the diaphragm right here. And the clinical correlate with that is diaphragmatic herniation. So it's congenital diaphragmatic herniation, essentially an issue with pleural peritoneal folding. Essentially, it means your diaphragm's not forming correctly. That's like the big issue. So your organs that should be down yonder in your stomach are going to push up. So your heart's going to get pushed over to the right side. You're going to have a lot of GI issues. Essentially, the child's going to present with gastrointestinal distress. They're going to have respiratory distress. It's going to be a whole bunch of problems because everything's where it shouldn't be. Yeah, a big thing that you might need to remember for that is that the heart shifts to the right with diaphragmatic herniation. I mean, which makes sense because it's kind of pushing up and pushing it out. With that. Does anyone have any questions about embryo? I know I went through that really, really fast. Okay, someone said they're good. Okay, very good. Okay. Sorry, I only have an hour. I gotta speed, but all right, so starting with the big clinical, I keep saying clinical course, Jesus, the big objectives that you guys need to know for the exam. I'm just gonna cover like the small stuff that might come up just based off of the exam we took last year. Don't tell Dr. Deruzo. Yeah, I'll just give you the important stuff that you might want to learn a bit better. But starting off with your thoracic cage, knowing about the landmarks of the thorax. So jugular notch, T2, this guy right here, that little nub, that's your jugular notch. Just know that's it's at T2. That's the big one. There's a little bit of the arch aorta, but they don't talk about it, so I don't think it matters. But yeah, then you go into sternal angle. That guy is important. Sternal angle, when they talk about that, is essentially where the manubrium is meeting the sternal body. So it's at T4, T5, and there's a ton of important stuff. So if you say like the question is someone gets stabbed right at their sternal angle, God forbid, they're gonna have a lot of problems. And it might be a question along the lines of, would these things can be injured in this case scenario. So yeah, you have the beginning and the end of the arch of the aorta. The trachea bifurcates there. The zygous vein joins the SVC, and the descending aorta begins there. A lot of stuff. Then the other marker you guys might need to know is the inferior tip of the xiphoid process is at the T10 vertebra. For this one, it's more important for stuff down yonder. So it's liver, the central tendon of the diaphragms there. We're gonna talk about that in a second. So that might be important if something happens right at the xiphoid process that might damage the central tendon of the diaphragm. Yeah, those are the big ones for landmarks for the thorax. Of course, there's more stuff in your slides, but this is just the stuff that I think might come up. Yeah, going on. So talking about the parts of the thoracic cage, I promise I didn't just look up thoracic cage before I started talking. This is your thoracic cage. So you see the sternum, you have manubrium, you have the body of the xiphoid process, what I was just talking about. Here's your jugular notch up top, clavicular notch, clavicle, and you can of course see that rib one is right underneath the clavicle. So that's why when someone, if their question comes up, who knows, is talking about how you count down the ribs, you always start with rib two because you can't really feel rib one. But you will learn how to in OMM. So yeah, be prepared. When talking about ribs, you have 24 total ribs. Please do not say you have 12 total ribs. I know it trips people up for some reason. But yeah, 24 total ribs. And you have two apertures when we're talking about the thoracic cage. So the thoracic inlet is up top here. That's pretty much with your rib one, your clavicle. When we're talking about thoracic inlet, we also have thoracic outlet syndrome, which I'll talk about in a second. I know the name is counterintuitive, but I know I just said that word wrong. And then thoracic outlet's on the bottom here. We'll talk about that in a second too. And then sternum, another part of your thoracic cage that I just saw. You have your manubrium on top. This has the jugular notch, all the stuff I just talked about. For talking about where the ribs attach their attachment points when we're talking about the front, your first rib, of course, is going to attach onto the manubrium here. And then your second rib is going to go attached to the sternal angle, which is where your manubrium meets the sternal body. And then the body of the sternum is going to be ribs 3 through 6. Xiphosternal notch is rib 7. Thoracic vertebrae are actually my favorite because they're shaped like a heart. But they have two different types of costal facets, essentially. They have the ones that are on the body that you guys learned about. There's a superior and generally an inferior one. And then they have the ones on the transverse processes. Those are pretty much what are going to match up with the facets on the ribs. And like everything, there's typical and there's atypical. So typical ones, just know T2 through T9. They're the typical guys. So they have the regular 2 facets or 4 facets, I should say, on the body, and then they have one on both sides of the transverse processes. Then you have the odd ones, the atypical T1. He only has an inferior costal demifacet, and then T10, 11, and 12 have one whole costal facet. When they talk about demifacet, essentially, it just doesn't mean it looks like a circle like that. It's just kind of cut in half. This is important. Okay. I think this was a question. Talking about where the ribs actually meet when they're talking about where they connect to the vertebra. If you have, let's say, rib rib 5. Rib 5 is gonna, for the most part, go to thoracic vertebra 5. So when we're talking about that, we essentially mean that the rib's gonna come onto the transverse process of T5, and it's gonna go to the inferior or the superior facet of T5. Because remember, it's going to be like the rib, and then it's going to be the vertebra right here. And then there's another vertebra on top. So when it's going over to the body, it's also meeting with the inferior facet of T4. So you have T5 superior facet, and you have the inferior facet of T4, and then the transverse process of T5. Just remember, rib 5 would be 2 on T5, and then 1 on T4. Might come up just as a trick, but... atypicals, I'm not going to go through this because it would just be reading off the slides, but just know them. I did come up For rib wise, it's probably going to be something along the lines of if you have a first rib, which of these is true? Like, will they have a sharply curved angle or will they have a really long one? Yeah, just know the oddities because they will probably come up. But yeah, I have them listed if you guys want to just point blank memorize them. So rib function, we're gonna learn about a lot about this in OMM, but just remember the ones on top, T2 through 6, they're all pump handles. So essentially what that means is it's going from um, down and back and it's going up and forward like a pump handle, which like a water pump handle, just to clarify. So yeah, just up and forward like that. And that's going to increase your AP diameter. So anterior to the posterior side is increasing in a pump handle. For buckhead handle, that's 7 through 10. That's more involved with the transverse diameter, so like that. And for those, it's like a bucket, like literally a bucket handle. So it's moving upward and to the side. So like that. That could come up. But yeah, just remember those are 7 through 10. The reason I don't mention rib 1 is because it doesn't really move that much. It more so moves with the manubrium. I don't think it comes up, but yeah, just T2 through 6 pump handle. All right, naming the 3 layers of the intercostal muscles and explain their function and respiration. You'll see this in lab, but external intercostal muscle is the outermost, and that one is kind of like shoving your hands into your pockets. That's how it's oriented. Again, more important for the practical, but just, they go down like that, and they're more involved with inspiration. They're the only one of the intercostals that's involved with inspiration. They help to inspirate. Then you have the internal intercostals, and then you have innermost. Both of those are involved with forced expiration. And they're more so the opposite direction than the external goes like this, internal. Um, yeah, I don't think the fiber ways they run will be that important, but just remember which one does inspiration. Okay, so forced inspiration, I do believe there was an objection on this. But and you could again, this is another thing that you'll just have to memorize. For forced inspiration, you have pec major, minor, serratus anterior, and the scaling muscles. They're all accessory muscles. So essentially, if a patient comes in who says like they're overusing their accessory muscles, that means they're having a really hard time breathing in. Like that's that. So it might be something wrong with their diaphragm, might be something wrong with their phrenic nerve. Hint, hint. So just to keep that in mind. Um, and then you have transverse thoracic, which is very deep inside. It's not technically one of the intercostals, I don't believe, but it's continuous with the transverse abdominis muscles. Just something to keep in mind. Just like the external intercostal muscle is your external oblique. So just remember that, like the name gives away, internal oblique, etc. I don't think they've asked that, but all right. Describe the position of intercostal vessels and nerves with respect to the ribs. You have something called the neurovascular bundle. It runs between the internal intercostal and the innermost intercostal muscle. So you have internal and you have inner, and it's running between the two of the muscles. So this guy and this guy is running right between the two of them. And it goes vein. So on the top, you have vein, artery, and nerve. The reason that's important is because the nerve is the most exposed. It's not really deep inside the costal groove. So that means if, like, let's say you're doing thoracocentesis, hint, hint, another important thing for the exam, and you accidentally bring it up too high, you can damage the nerve. So just important to know that. Describing the blood supply. I'm gonna try and avoid the blood supply questions because they're the really best way to learn them is just to remember like the pictures. Honest to God, just go through these and do them 1,500 times. Like that's just the best way to remember, especially venous drainage. They like venous drainage. Um, for blood supply, same thing again. Just try and go through it, write it out, make a diagram, and that'll help a lot. Yeah, because just reading off it probably wouldn't be that helpful, but yeah, just go through it that way. Innervation for the thoracic wall is there's the anterior and the posterior rami of T1 through T11. Remember again, there's the anterior rami, so the ones in the front, and then you have the posterior, the ones in the back. Your posterior rami, as the name kind of gives it away, it's going to go to the back in this case scenario. It's going to go into your deep muscles in the back on the overlying skin. Anterior ramus is the one that's more involved here, where with what we're talking about with intercostal nerves. Then you have the ramus of 12. He becomes the subcostal nerve. If you guys remember from the lumbar plexus, that one nerve that kind of stuck out the top, that's the subcostal nerve, which is just T12. Um, For this, yeah, just remember that the anterior rami are doing the intercostal nerves. Um, Again, there's typicals and there's atypicals. Typicals, I would remember to innervate the intercostal muscles in the parietal pleura. So this right here, just remember they do that. It would be good to know the branches, like it couldn't hurt. Um, yeah, so just remember those for the typicals. T1 is important. If you remember brachial plexus, T1 is a part of that. So he's going to come off and join as the brachial plexus. And he's also going to have a branch that comes down and becomes the first intercostal nerve. So just remember that he has two branches. Well, he has other branches, but those are the big two. There's usually not an anterior cutaneous branch. What else is important? Um, yeah, you can just remember the small things about the atypicals. It might be better than just learning the typicals. Not that you shouldn't know the typicals, but you know, they're usually what they like to ask about. So for second intercostal nerve, just know it supplies the floor of the axilla, and it becomes intercostal brachial nerve. 7 through 11, these guys are going to supply the abdominal skin and musculature. They become the thoracoabdominal nerves, which is important. They also do, they're pretty much going to pierce through rectus abdominis. Again, don't know how important that would be, but yeah, atypicals have to learn. Dermatomes, these are the important ones that I pulled for you guys. I think they're on their slides too. Um, just if you can figure out, like, remember these guys, point blank, you can kind of figure out what the other dermatomes are. Like if they say like something like right below the clap, like rib 2, they got stabbed by something or something. You can remember C5 is right here, C6 is gonna be right below. Yeah, just the dermatomes for your abdominals and your thoracic. It's just they're all in order, so makes it kind of easier. But yeah, remember umbilicus is T10, inguinal region L1, etc. Describe how much time do I have? Oh my God. All right, describe the anatomical structure of the breast. It's a modified sweat gland. I would know the drainage, so remember that it's going from these lobulars. I have a picture. You have your lobules, and then they're going to come off right here. They're going to go into your lectiferous ducts, lectiferous sinus, and then through the nipple. Yeah, you just can remember that order. Lots of sebaceous glands. Keeps it not dry. And then you have your retromammary space. This is a potential space between the glandular tissue and the pectoralis fascia. This because remember the breast is on top of pectoralis major and serratus anterior. So there's just this little space between the two and allows a little bit of movement. Um, I just talked about serratus anterior. Just remember second to sixth rib. And then know the lines is it could be helpful for the practical too, to remember like where the axillary line, remember where mid-clavicular line is, just to have those like in mind, because they do become helpful. Um, Lymphatic drainage. This is actually very important. Um, did I not put it? Oh wait, I put it below. Okay. All right, so here's the lymphatic drainage for each quadrant. Remember that there's a medial side, there's a lateral side, superior, and there's inferior. It's not like one quadrant is one, it's more like a sides done by both. Um, the biggest one to remember though is the axillary lymph nodes. These are really, really important when it comes to breast cancer. Specifically, there's adenocarcinomas, they happen the most often. They rise from lactiferous ducts. Um, and for these, another important thing besides like knowing where to look for axillary lymph nodes is that if you do a mastectomy, you're probably going to damage a lot of axillary lymph nodes, which is going to cause a bunch of lymphedema up in your arm. So just to keep that in mind that you have a patient that presents just had a mastectomy, suddenly they have a their arms becoming enlarged. What might be the reason behind that? And you got it. Yeah, and then they also brought up one of the signs for breast cancer. I cannot pronounce this right. I'll try my best. Peau d'orange. Essentially means like orange skin. It's a type of edema. It's a blockage of the superficial lymph drainage that pretty much causes a ton of fluid to build up, which causes the dimpling that looks like an orange peel, hence the name Peau d'orange. So yeah, that's just something to keep in mind. It might come up. I don't know why they brought it up, but yeah, just keep it in mind. You see the dimpling, that's because of a blockage of the superficial lymph drainage. And do know the drainages. Parietal and visceral pleura, also very important. So when we're talking about the pleura, we're essentially talking about this lining that does, can I zoom in? There you go. Pretty much all around the outside of the lung. and around the thoracic cage. Not around, inside the thoracic cage. Pretty much keeping it protected. So when we talk about that, you have probably heard the balloon analogy like 1,500 times. Essentially means like it's two layers. There's the parietal and the visceral, and it's not like they're surrounding the lungs themselves. It's like they're kind of like a balloon. Like they're out here, and then the lungs pushing into the two layers, and then they have the serous fluid inside. It's not that the lungs are inside of the pleural, but then when they form that little balloon-like area, then underneath the balloon is the pleural cavity. So this area right here is pleural cavity. Uh, or sorry, pleural cavity is between the two layers. Anyways, and then you have your lung beneath. All right, so going into, oh yeah, you have recesses too. These are good to know, specifically the costodiaphragmatic recess. It's important for pleural effusion. It's between the eighth and the 10th rib. So essentially you have a patient presenting like this feeling of fullness in their chest, difficult time breathing. Um, and that you know that the fluid's probably going to build up right in the costodiaphragmatic recess just because when you stand up, that's where all the fluid's going. It's going right towards the bottom. So just a good clinical vignette right there. So going into the difference between parietal and visceral. So parietal is the parent. Parietal covers everything aside from the lung. So you're going to have it covering the thoracic cage, and it's going to cover the diaphragm as well. Or well, it's underneath, I should say, and then on top of the diaphragm. And that's split into four parts. You have your cervical, costal, diaphragmatic, and mediastinal. The name gives it away. Don't overthink it. Just think about the names. Diaphragmatic right on top of the uh, diaphragm. And when they're talking about the mediastinum, I don't even know if they've covered this yet, but mediastinum is kind of this area between the two lungs. It holds a ton of important stuff. You'll learn more about it in cardio. You'll hear me talk a lot about it during cardio. Yeah, that's just what that means when talking about mediastinum. It's just the center. So mediastinal, the pleural is going to be right to the side of that. And essentially, the important one for those is mediastinal, just because it forms the pulmonary ligament that allows for expansion when you're breathing in, especially during exercise. Yeah, just keep that in mind that mediastinal is going to fold and form the pulmonary ligament. Okay, but yeah, just those four. Just remember that the name gives away where it is. Then you have the three pleural reflections. You have your sternal line, your costal line, your vertebral line. I won't go too deep into those. The name kind of gives away. That's just the line where the two different types of pleura meet. And you can probably know where they are as well. And just remember, if you puncture the pleura, your lung's going to collapse. That's important for clinically as well. Another important thing for parietal pleura is it does not cover the hilum. None of the pleura cover the hilum, I should actually say. So when we're talking about the parietal versus the visceral pleura, parietal has somatic innervation, which essentially means it's pain sensitive. So the outer covering, that covering that's covering like the ribs and going down to the diaphragm, all the outside, that is pain sensitive. So if you get stabbed there, you're gonna feel it. So that's somatic innervation because you can feel it. We can't like feel it right now, but yeah. They can know the blood supply as well. Again, veins, lymph nodes. Just have to remember them. Visceral pleura. Cool thing about it is that you can remember that it's attached to the lung. That's what it is. Visceral pleura is sealed on top of the lungs. So essentially that kind of gives away the fact that it's supplied by the bronchial arteries, thankfully. And also has the Azia system, but that's less obvious. But yeah, that's an easy way to remember its bronchial arteries is because it's literally sealed on top of your lungs. Then you have the bronchopulmonary lymph nodes. But the big thing for both of these is that their innervation is different. So again, you have the parietal, which is somatic, pain sensitive, and visceral is autonomic. So that means it's pain insensitive, can't feel it. Which could be a problem, I guess. So then what I talked about earlier was thoracocentesis that comes up with the whole van thing, vein, artery, nerve. So thoracocentesis is done by the ninth intercostal space at the mid-axillary line. That is important. That could be an exam question. And again, you're gonna have to do it just above the rib. Just, again, making sure you're missing that van. That sounds bad. You're missing the vein, artery, nerve, the neurovascular bundle, just to avoid any damage. It needs to be angled upwards so you don't stab the diaphragm, which is right below. Which is another good way to remember where the diaphragm is. How am I doing on time? Okay, I'm talking so fast. I'm so sorry. So describing the lobes and the fissures of the lung. This is pretty easy, just remember superior, middle, inferior for the right lobe, the lung, and then remembering on the left lung is the odd one. So there's a superior and inferior lobe. There's not a middle lobe. That's because it needs to have that space for the heart, which is where the cardiac notch is. Another thing about the left lung, there's the dog, is that you need to know about the superior lobe has the lingula. I believe that was a test question last year. Is that lingula is in superior lobe. It's the goofiest thing, but it tripped everybody up for some reason. Yeah, just remember those little things like that can come up. Go away. And then for the apex, know that it's relation to the subclavian artery. A couple of these areas do have relations to specific arteries that could be helpful to know. But yeah, just remember those. Two bronchial arteries on the left lung, only one for the right, could also be important. So talking about the roots of the lung, again, this is going to be more of a practical issue. Not an issue, this is important to know. But yeah, just remembering that the arteries found anterior to the primary bronchus on the right side in comparison to the left. Just those little things. They could make a question about that, so I mean it couldn't hurt to know. Yeah, just remember that the hilum there, that what I talked about, that's not covered in pleura, remember? That's where all of the roots are going to come in. So you have the bronchus, the arteries, and the veins are all coming in through the hilum. And the hilum is that little middle part in the lungs. I can't see in that picture, but yeah. Fissures, it could come up to know where exactly the fissure is. So knowing the oblique fissure extends the spinous process of T2, that could be important in the costal cartilage of the sixth rib. Honestly, really from the picture, you could probably get that too. Just remembering where they line up. Then there's a horizontal fissure. He runs along the fourth rib. Again, that could come up. Describing the anatomy of the trachea and the division. The big thing when we're talking about the trachea is remembering that the right main bronchus is short and wide. So that means if you inhale for an object, it means it's probably going to lodge itself in the right main bronchus. So that's an important question for like a clinical event. Yeah, right main bronchus is probably where something that's inhaled is going to end up. Explaining the blood supply, the lung, and the pulmonary circulation. This is a circulation question. I won't go too into it. Again, just draw it out. Draw out the arteries in this area. Draw where they're going to, what they're supplying, and you'll have it. That's just me reading it out. I don't think will be that helpful, but try the lymphatic drainage. Again, another thing that is not going to be big for me to read out. So describing the innervation of the lungs and the pleura. So they're innervated by the anterior and posterior plexi. What that means is essentially the autonomic plexus. You have the parasympathetic fibers from the vagus nerve, and then you have sympathetic fibers from T2 through T5. Could be important to know. Then a bunch of other stuff that's not. I would just be reading off the slide. All right, big thing going into the diaphragm, definitely need to know is that central tendon I talked about earlier. Know the embryological derivative of that. Yeah, so essentially the tendon is fused to the inferior part of the fibrous pericardium. And it's this guy right here, this big old chunk of tendon. It's really important because when you breathe in, it's pretty much depressed, which allows the space to build up. So there's three parts for the diaphragm. There's the sternal, costal, and lumbar part. So you have your sternal part up here, it's tiny, attaches to the xiphoid. Then you have the costal parts over here. These guys, there's two of them. They're the inferior six costal cartilage. Then you have lumbar part in the back here. He's going to form two arcs, or cruce, sorry, the right and left cruce of the diaphragm. And the right and left cruce are going to be united by median arcuate ligament. I think you can see them on here, but yeah, just good things to know. Diaphragms have three openings. Definitely know the openings for the diaphragm. Know the caval opening. Know what's inside of it. Know where it is. So caval openings at the T8 vertebra has IVC, right phrenic, and lymphatic vesicles passing through. Esophageal hiatus, name gives away. Esophagus goes through it. But also remember that the vagal trunks and the esophageal and left gastric vessels are going to go through there. Specifically the vagal trunks. Know that the vagal trunks are going through there. And that's at T10. And then you have the aortic hiatus. This is where the descending aorta, esophagus vein, and the thoracic duct go through. Another really important one, that's at T12. Um, Also, more for the practical, know where they are. It wouldn't couldn't help. Um, right, and then lastly, for the diaphragm, know that the phrenic nerves innervating it is C3 threes to C5. Remember you saw it with the brachial plexus. It does motor to the entire diaphragm, and it does sensory to the central tendon. And then you have the lower five intercostal nerves, which are sensory to the peripheral aspect of the diaphragm. And somehow I managed to get through all of that in 30 minutes. All right, does anyone have any questions or need me to repeat the whole thing? And thank you to whoever keeps sending the document in the chat. You're the best.
Thank you so much. That was pretty much all the high yield stuff from what you could remember from like your past exams and everything.
Yeah, for the most, we had, of course, we had different exams last year, so it was a little bit harder to figure out exactly what you guys might come up that came up on the last exam. But again, I think I pointed out pretty much all the ones I remember that might come up again. That could be repeat questions, just throwing out there. Uh,
Thank you.
I have not heard anything about a TA review. They haven't asked us to write any questions yet. But I can reach out to Tyler and hopefully we'll be able to get some questions. Maybe they're just the head TAs are writing them, but I haven't heard. Do you guys know how many questions are actually anatomy? Like on this? Nine? Oh my God, I talked so fast for 30 minutes for nine, but no, I'm just kidding. Yes. All right. Well, at least thankfully this information is not too crazy, so I think you guys got this. Um, Embryo wise, I'm I would bet money. I would bet serious money. They're probably going to give you this, and they're probably going to ask you when the development for the lungs is far enough that the child will survive without getting respiratory distress in them. Well, they'll probably still get it, but nice, Alan. Does anyone else have any questions? Um, I know I went through that so fast. Oh my God. Sped run. If not, I can try and come up with some questions real quick and see if you guys can answer them in the chat. If I did that in 30 minutes. I like the thumbs up. Thank you, Alan. All right. I'll try to, can I end? How do I stop sharing the screen? Okay, I'll come up with quick question to give you guys. All right. Maybe better if I just type it up. No. All right, in the chat, can you tell me, patient tells you she just had a mastectomy. Which lymph nodes are you worried about? Or I should say, what condition are you also worried about? Good job, Drew. Nice job. Yeah, just remember that might come up. It's also a good thing to know in general life that if you have a mastectomy done, that you might have. Oh, good job too, Miss Abraham. Yeah, you can also have wing scapula. They brought that up in the slides. Lymphedema is usually the big one for that though. All right, next question. Uh, Patient presents with a pleural effusion. Which recess is it likely in? And pleural effusion means liquid in the cavity, the thoracic cavity, as you know. Good job, guy. I expect you all to walk into supplemental tomorrow, like fully prepared. Guys, you
For
be proud.
I have a quick question. For the fluid in the cavity, does it matter on what position the patient is in?
It would actually. Um,
That's why I was a little confused, sorry.
yeah. Usually they would present with it like the patient will be sitting up and they'll feel it. So they would feel it in the costodiaphragmal recess. But when they are laying down, yes, it can become a problem when you're talking about the other recess as well.
Okay. What
Yeah, usually.
do you know by chance? If not, I can go back to lecture. If it is a patient that's lying down,
Hmm?
where the recess would be or the fluid?
I'm sorry, what do you mean?
Um, so where would it go? Because